Welcome, everyone, to today's virtual policy forum, Improving Lives, Policies and Practices for Opioid Use Disorder Prevention and Recovery. We're very glad to have you join us today for this timely conversation. So to begin, we're going to start with a poll. So please take a moment to pull out your phones and register for the poll by texting Health Policy 261, no spaces, to 22333. Again, Health Policy 261 to 22333. Or you can join us by visiting pollev.com/healthpolicy261. Again, pollev.com/healthpolicy261. And our question today will give everyone a sense of who's joining us today in the audience. So the question is, what role or roles do you play in understanding and addressing opioid use disorder? You can select up to 2 options here. So these might be a professional connection, a personal connection, volunteer work, etc. So let me take a look at what we're seeing here. Thank you. So it looks like we have quite a few health plan folks joining us, policymakers and staffers, provider organization representatives, advocates, and nonprofit organizations are also represented. I'll give folks another few minutes, a few seconds to select a choice. And thank you again for joining us. The information is on the screen in terms of the number to text or how to join us by web. Wonderful. So seeing many policymakers and staffers represented in the audience today, followed by health plan folks. And again, remember, you can select up to 2 options. So a few folks with lived experience, academic researchers, really very interesting. Thank you so much to all of you for joining us. So I am Cecilia Oregón. I'm the Executive Director of Kaiser Permanente's Institute for Health Policy. And at the Institute, we host events and publish information to shape policy and practice on important topics. We convene experts to share knowledge, spark discourse, advance collective thinking, and explore opportunities to cultivate healthy communities and promote more accessible quality care. Overdose remains a leading cause of injury-related deaths in the U.S., and most involve opioids. Given the current crisis, we want to learn more about what's working to prevent addiction and to reduce overdose deaths. And I'm pleased to kick off today's conversation with leaders who are working to shape public policy at the state and federal levels in ways that will support and enhance recovery and care. So first, a little bit of housekeeping. Both after our keynote speaker and the panel discussion, we'll be taking some questions from the audience. You can submit questions through the Ask a Question box on your screen at any point during the forum. If you're on a large screen, you should see the Ask a Question box on the right of the main window. And if you're on a smaller screen, it'll be right below. We likely won't have time for every question, but we'll do our best to ask as many as possible. If at any point you experience technical difficulties, please submit a question to the host through the Ask a Question box as well, and we'll also do our best to help resolve technical issues. The event is being recorded, and the video will be available within a few weeks on the Institute for Health Policy's website. So on to our content for today. It's my pleasure to introduce our keynote speaker, Dr. Sheila Vakharia, Deputy Director of the Department of Research and Academic Engagement at the Drug Policy Alliance, or DPA. In her role, she creates awareness on a range of drug policy issues. Dr. Vakharia builds relationships with drug researchers and helps to advance policy research. She also mobilizes researchers in support of DPA's campaigns and organizes conferences on key issues in drug policy. Dr. Vakharia is the author of The Harm Reduction Gap helping individuals left behind by conventional drug prevention and abstinence-only addiction treatment. And before joining DPA, Dr. Vakharia was an assistant professor of social work at Long Island University. She's also worked as a clinical social worker in both abstinence-only and harm reduction settings. Her research interests include harm reduction therapy, drug policy reform, drug stigma, overdose prevention, and social work education. She is on the board of directors of Filter magazine. She also received her PhD in social welfare from Florida International University, a master's in social work from Binghamton University, and a postmaster's certificate in addiction from New York University. We're truly honored to have such an incredible champion of this work join us today. So now I'll turn it over to Dr. Vakharia.
Good morning or good afternoon. Thank you so much to Kaiser Permanente and our hosts for hosting this event. And I feel deeply privileged to be in the company of the panelists who have joined me here today. So my talk is going to be a broader framing to set the stage for this panel about the current overdose crisis as it's unfolded over the past 2.5 decades, and to end with some policy interventions and notes for us to consider in taking steps to save lives. So I think it's really important to talk about this overdose crisis as one that's unfolded over the course of the past 2.5 decades in a series of 4 waves. And I feel like the 4-wave framing, which was coined by Dr. Dan Ciccarone, does an excellent job of really distinguishing the temporal, regional, and drug and demographic variations that have unfolded in the overdose crisis over these past 2.5 decades, highlighting key shifts that were often driven by policy changes that had tremendous public health effects and implications on the ground. So here I have a graph of the timeline that will show the unfolding of the crisis over the past 2.5 decades. And I'm going to start with the involvement of prescription opioids in overdose deaths. I believe many of you are familiar with what many researchers are calling the first wave of this overdose crisis, right? Due to pharmaceutical deregulation, marketing practices, and the advancement of profit over health in actually addressing unmet needs in our communities for pain and other kinds of treatment, the provision of prescription opioids as a cure-all or catch-all is quite reminiscent of actually an overdose crisis, an opioid overdose crisis that we as a country experienced almost a century ago, in which folks were told that they were being given a medication that could treat pain that actually was quite effective at treating both emotional and physical pain, but that oftentimes was not provided to patients with adequate education or information about risk, and that was often promoted with profit in mind. And so what we saw in the beginning of the early 2000s was the ramifications of rapid policy change and implementation practices around prescription opioid provision that led to increasing rates of overdose, largely in rural Appalachia, and that the media at the time coined as being a crisis that was unfolding in otherwise unheard of or unusual communities that were not seen as having risks for opioid addiction. And what I mean by that is that much of the media depiction and public depictions of the beginning of the overdose crisis was that an unlikely group of new people and users were introduced to illicit drug use. And here they were becoming addicted due to no fault of their own, largely trusting their medical providers. And health economist Casey Deaton argued that these white people who were dying of overdose at higher rates in rural Appalachia, who were blue-collar workers, middle-class people, who were the unlikely new face of addiction, were experiencing what they coined deaths of despair, meaning that alcohol-involved deaths, suicide-involved deaths, and opioid-involved overdose deaths were increasing among this population. And steps were then made as the overdose deaths started to increase to try to restrict access to these prescription opioids. First, through targeting prescription practices of prescribers and doctors, but also through targeting where these medications were dispensed, its so-called pill mills, and also to raise awareness of the risks of prescription opioid use. However, one of the challenges in going forward with this strategy was that the underlying reasons for people using opioids and engaging in higher risk practices were never truly prioritized. Instead, we prioritized supply side interventions to reduce the availability of these substances. And might I note that Friedman, Hansen, and Dr. Gahn have published extensively on indigenous data genocide, in which actually arguments about white despair leading to increases in overdose deaths neglected to include indigenous overdose deaths, which since the beginning of this crisis have actually been in parallel and in tandem growing at tremendous rates along with white overdose deaths. But the framing of this first wave as a white crisis was a deliberate comparison between white communities and Black and Latinx communities using data that ended in 2013 and excluding Native data because of the small sample sizes. So what we saw when we started to restrict access to these prescription opioids was that the demand remained, and people turned to the underground market to meet their desire for opioids, for physical, spiritual, psychological, emotional pain. And what happened was people went from a known dosage and milligram potency to an unknown supply, because on the underground market, prescription pills also became more and more expensive. Yet heroin, actually around 2008, 2009, became readily available in many of our underground drug markets and became quite affordable. And DEA seizure data shows that actually heroin availability was rapidly increasing. And that's when we saw the beginning of the second wave of this overdose crisis. Many people transitioning from prescription opioids to the underground heroin market because it was more cost-effective and affordable, yet without adequate tools and strategies to reduce risk and to stay safe using an unregulated supply, people were dying of overdose. And as overdoses involving heroin began to increase, what we started to see were increased seizures and busts, both at the border and across the United States, to restrict the heroin supply. And yet again, the prioritization of supply side interventions rather than the expansion of harm reduction, public health, and treatment efforts really led to people shifting rather than actually being able to transition off of using those drugs or starting to use those drugs safely. Yet heroin is dependent on the life cycle of the opium poppy plant. And so as more and more people were turning to the underground heroin supply and this supply was getting squeezed, drug suppliers realized that they could not possibly keep up with demand with simply growing the life cycle of a poppy plant. And so by dipping into old research from the 1960s from Janssen Pharmaceuticals, who had developed fentanyl, a highly potent opioid to serve in very specific medical circumstances to help with rapid surgery needs, and also that would rapidly wear off so that patients could be sent home faster after having intensive surgeries. This pharmaceutical recipe was made available to underground suppliers who found that it was far more cost effective and affordable to secure the precursor chemicals to make their own fentanyl rather than to wait for the life cycle of a poppy plant to produce enough heroin to meet demand. And so what we saw was that drug suppliers understood that when drugs come into this country, that oftentimes along the supply chain, drugs are interdicted and supply chains are disrupted, and often the quality goes down. But by introducing a more potent and smaller and easier and more discrete chemicals over the border that also required less production costs and timelines, they could actually maximize their revenues while also still meeting demands in our communities. And so around 2013 and 2014, we saw the introduction, especially here on the East Coast, of illicit fentanyl mixed into China white powder heroin that is largely sold here on the East Coast. So Baltimore, DC, Boston, 2013, 2014, early studies were showing that community members were noticing that their heroin supply had changed. They noticed that there was a quicker onset in the effects. They noticed that it didn't have legs, meaning that the effects wore off quickly. And oftentimes people would overdose before they even realized that the needle had entered their arm because of the rapid onset of the effects. And so this is when the third wave of the overdose crisis began. And many of us need to remember also that our drug supply chains are not racially or geographically distinguished in terms of rural and urban. And so at a time when entrenched heroin markets in major urban centers all across the country had longtime users of heroin who knew how to stay safe with heroin and were not facing overdose death, all of a sudden, drug supply chains shifted in both urban and rural areas, with both new and older users now being subjected to a highly potent drug supply. And so this is actually when we also started to see a shift in the the distinction between rural and urban overdose deaths because we started to see overdose deaths increase in our major cities. But this is also when the face of the overdose crisis began to change. This is when in larger cities like New York City, Boston, DC, Baltimore, and Chicago started to see that the face of the overdose victim now was a Black face. And it was often a man, and it was often an older or an elder man, rather than this idea that we had in the early waves of the crisis of a white, rural, young person. And so the third wave of the crisis is a really important wave for us to kind of recognize, in that the emergence of fentanyl into our drug supply adulterated the drug supply that had otherwise been relatively stable. And now we started to see the emergence of racial disparities in more of these overdose deaths. And yet at the same time, we were building the foundation for what is now known as the fourth wave of the overdose crisis. The fourth wave of this crisis being characterized by not only fentanyl-involved overdose deaths, but also the co-involvement of stimulant drugs, namely methamphetamine and cocaine. And so if you look here in this fourth wave of the crisis, you will see that the top line, the dark line, still remains the fentanyl line. As of the data that we received just from this past year, the provisional 2023 data, we still know that fentanyl is driving about 75% of overdose deaths. Yet, the number 2 drug involved in overdose deaths nationally is methamphetamine, and the number 3 drug being cocaine. You will see here that the prescription opioid line, which is that red coral color, and the heroin line, that is the orange color, have actually remained relatively stable and actually have gone down. It's really important for us to also acknowledge that in the wave 4 of this crisis, those of us on the East Coast have seen a saturation of fentanyl into our drug supply, but now those of you on the West Coast have seen an uptick in your overdose deaths, particularly involving fentanyl, because fentanyl emerged in your drug supply through the provision of counterfeit pills, but also through the sales of pure fentanyl by itself, and people largely smoking those drugs. And so I think it's really important when we talk about this overdose crisis to recognize the changing drug landscape, the changing policy landscape, the changing demographic and rural and urbanicity factors, but also the regional shifts that really characterize these distinctions. And I think it's really important for us to think about the broader policy changes. So as I said, restrictions on prescription opioids only led to an explosion of our underground heroin supply. Restriction of our heroin supply only led to the emergence of illicitly manufactured fentanyl. And when people started using highly potent fentanyl, they were often offsetting these unpredictably potent downer effects with uppers, and many people are co-using methamphetamine or cocaine along with fentanyl to deal with these effects. And yet, what did we do on the federal level? In 2018, Congress went ahead and made fentanyl and all future fentanyl analogs, such as carfentanil, acetylfentanyl, fluorofentanyl, into Schedule I substances. Again, with the argument that perhaps if the penalties are harsh enough, people will stop trafficking in fentanyl. Yet what did we see immediately after 2018? That slope only went up. Then we also saw, and start tracking that data, that the emergence of sedatives and novel psychoactive substances has only increased. So xylazine, which is a veterinary tranquilizer and sedative medication, has emerged in our underground drug supplies, so that in communities like Philadelphia, 99% of people who die of a xylazine overdose thought that they were buying fentanyl, and it was xylazine adulterated fentanyl. We've also seen our neighbors to the north in Canada, etizolam being the sedative that's been largely mixed into their fentanyl supply. So the emergence of these novel psychoactive substances, which provide the fentanyl legs through the longer sedative effects that can help delay the onset of withdrawal symptoms, has actually created an even more unpredictable drug supply that's actually become more potent, that's actually become more dangerous, and that's been associated with even more harms. And all of this really being driven by policy change. And then, of course, we can look to COVID-19 pandemic, where again, it was after 2020 that we finally in 2021 saw such a dramatic increase in overdose deaths that we saw our first year of losing over 100,000 people to overdose death. And in the 3 years since then, 21, 22, and now in 2023, we have now seen over 100,000 people dying of drug-involved overdose deaths, a number that cannot be our new normal. And although many in the media are championing a 3% reduction nationally, in no way does this mean that we should be sitting on our heels or patting ourselves on the back. There is still so much we need to do. And so in terms of the 3 main policies that I would really like to push forward for all of us to be mindful of is, first and foremost, in this fourth wave of the crisis, when Black, Brown, and Indigenous people are dying at high higher and astronomical rates of overdose, it's clear that colorblind policies will not save lives. And if anything, when embedded and implemented by systems that are marked by institutional racism, will only affirm those same inequities, because the communities who are most impacted are also the ones who are often most left behind by these systems. We also need to acknowledge that criminalizing drugs, the drug supplies, and the tools that people use to consume drugs, whether it's smoking equipment, injecting equipment, the drugs themselves, will lead to increased overdose risk. And we know that transitioning from injection drugs to smoking drugs is a form of harm reduction, but we also know that there are many states in this country where access to smoking equipment is not available. But we also know that overdose risk upon release from incarceration increases the risk of overdose by over 27 times in the first 2 weeks of release. And lastly, I would argue that we must look beyond opioids and move beyond an opioid playbook to truly help people who use stimulants and those who engage in polysubstance use to help reduce the likelihood of overdose death, because it's not just an opioid crisis. The longer we call it an opioid crisis, the more we crack down on opioid supplies. When we look at it as an overdose crisis where people are dying, we can implement solutions to actually save lives.
Wow, incredible. Thank you so much, Dr. Vakharia, for sharing this information with us on the waves and on the role that stimulants and other drugs are starting to play in this crisis. I guess I wanted to think a little bit with you about the 3 areas that you just mentioned, where there's action steps that should be taken, and in particular in thinking about the diverse populations that are now being exposed to this. Can you talk a little bit about what you might hope to see from policy reform action in the future in these areas?
Absolutely. I mean, I think first and foremost, when it comes to inequities in our systems, we have to measure them and we have to evaluate them before we know how to intervene. And so documenting these racial disparities, I think, is really important first and foremost. But then I think it's really important for us to think about the ways in which that's playing out in service provision and service delivery. We know that people receive better care from providers who look like them. And I think it's really a workforce issue that we must acknowledge in the fact that we do not have culturally competent services that are provided, and oftentimes providers do not resemble culturally, linguistically, or physically the communities who are most impacted. And it's those disconnects that keep people out of care. We also need to think about inequities in access to private and public health care and insurance. And we need to think about barriers that people face when they do want to enroll in evidence-based treatments, because we know there's tremendous disparities in access to evidence-based treatments such as buprenorphine, which we know Black people with private insurance are 60% less likely to receive a prescription than a white person. And we know that our methadone treatments, which are the gold standard treatments internationally recognized for opioid use disorder, are systems that provide methadone look more like jails and prisons than they do medical facilities. And why is it that we have such punitive carceral logics embedded in how we are supposed to be providing a life-saving medication that can cut the fatal risk of overdose in half among people? I think we also need to have frank conversations about the ways that criminalization through heightened surveillance of communities of color really leads to targeted enforcement and disproportionate policing and arrest rates, and also incarceration rates. I think that we can't just act like our criminal legal system is colorblind or race neutral because of the way that it was designed. It is operating as it was designed. And lastly, I think that, again, having an opioid-centered playbook, again, will leave behind communities of color who use stimulants, because Native communities have the highest rates of methamphetamine-involved overdose deaths, and Black communities have the highest rates of cocaine-involved overdose deaths. The more we make harm reduction programs or healthcare programs syringe-centered or opioid-centered, the more we leave behind people who smoke their drugs or snort their drugs, who could be getting connected to services through the provision of these tools, but then learning about Naloxone, learning about fentanyl test strips and xylazine test strips, getting an HIV test, getting a hepatitis C test, getting engaged in evidence-based treatments. And so I think that we also need to kind of look at how using stimulant harm reduction as a way to lead and engaging communities of color, particularly who are impacted, is another way to do this.
Wow, really powerful. Thank you. The audience question that we'd like to take very quickly is, what do you think wave 5 will look like? Or will there be a wave 5?
I think wave 5 is these novel psychoactives. I think we're going to see more sedatives. We're already seeing these sedative drugs. And again, it's the consequence of criminalizing and being more punitive on fentanyl and fentanyl analogs without truly ramping up in ways that we really could those evidence-based strategies. And I think stimulant-involved overdose deaths, sadly, are going to continue to increase because many people are turning to stimulants to offset those heavy sedative effects of fentanyl, but also these new sedative drugs. And so I think sadly, this new wave, if we are going to call one, it will be a benzo tranq wave.
Well, thank you. I think we are ready to transition to our next, our panel. So thank you, Dr. Vakharia, for this information. Really important to lay the groundwork for the following conversation. So thank you. So for our panel discussion, I'd like to introduce Dr. Sarah Bagley. Dr. Bagley is an associate professor of medicine and pediatrics at Boston University School of Medicine and is board certified in pediatrics, internal medicine, and addiction medicine. She's the founder of the Catalyst at Boston Medical Center, providing integrated substance use care and primary care for youth. Her passion is to ensure that all youth who use substances have access to high quality, equitable care to promote their health. Her research focuses on the engagement of young adults who use drugs and their families in care to minimize risk for overdose and the complications of drug use. Dr. Bagley has funding from the National Institute on Drug Abuse, the Centers for Disease Control and Prevention, and PCORI to conduct research about engagement in treatment and overdose prevention of young adults after non-fatal opioid overdose and reducing stimulant-related overdose. So welcome, Dr. Bagley, and to our panelists.
Hi, thank you so much for having us. And I just want to say thank you to Dr. Vakharia for really excellent remarks. It's always such a pleasure to hear you speak, and I learn something every time. So we get to transition to our panel presentation. So we have three excellent presenters or panelists this afternoon who I think are going to be able to provide some rich, they can offer their rich experience and expertise to the discussion that we're starting to have. We have Dr. Christopher Jones, who's the director for the Center for Substance Abuse Prevention at SAMHSA, Mr. Philip Rutherford, who's the strategy lead at the National Council for Mental Wellbeing, and Dr. Ebonie Vázquez, who's board certified psychiatrist and addiction medicine specialist, the chief of service at the addiction medicine department at Kaiser Permanente, Baldwin Park, and the regional chief of service for addiction medicine at Kaiser Permanente, Southern California. Welcome to all of you. So I'm just going to sort of set the stage for the next hour or so that we're going to be together. I'm going to ask each panelist to give brief remarks, and then we're going to go into a facilitated conversation with some questions that we've already predetermined, and then we'll be able to open it up to audience questions, and that will get us to the end of the hour. Before we get started, I wanted to sort of reorient us to the objectives of this event, just so that we're sort of starting on the same page. I think Dr. Vakharia, I think expertly provided us with this overview of the current crisis, how we got here, and really laid out some important policy opportunities so that we can, as we start to see this fourth wave emerge, really think about what we can be doing differently to try to mitigate the effects that I think we're already seeing in our communities and have been seeing, and really highlighted the importance of policy reform as a key component to mitigate those effects. We have in this panel, we're going to really be talking about opportunities for prevention, engaging people in care. And when I'm talking about care services, really thinking about harm reduction and treatment, the continuum, or maybe people want both. And so really trying to be flexible and responsive to individuals' needs. And then also, importantly, really assuring that as we think about sort of policy change and implementing new interventions, ensuring that it is equitable care and not actually exacerbating these inequities, these disparities that we have well documented. With that, I'm going to, and actually, as a board certified pediatrician, I'm going to sort of ask everyone that as we sort of go through the next hour, that we sort of consider teenagers and young adults, and we sort of think about sort of as we're answering these questions, what are the impacts on teens and young adults to ensure that they are sort of kept as part of the conversations that we're having. So I think I'm going to ask Dr. Jones to kick us off, please.
Great. Thanks so much, Dr. Bagley, and really appreciate the opportunity to be here today for the panel discussion. And Dr. Vakharia, thank you so much for your remarks and setting the stage for us as well. In the Center for Substance Abuse Prevention, we are really using that data that was just described in the keynote presentation to help drive our work. And I think a few highlights really underscore that we have to do things differently. We have to think in new and innovative ways as we approach our prevention work. I think the historic high levels of overdose, highly toxic and unpredictable drug environment really underscores across the lifespan that using drugs is riskier than it's ever been, and we need to do all that we can to save lives. And raise awareness about the fact that the pill that you got from your friend may not be what you think it is. And in fact, it's often, lethal doses of pressed fentanyl. But I think the other tension that we are always trying to wrestle with in the prevention space is that it's not choosing one or the other, addressing overdose or addressing upstream prevention, but it's actually doing both. And we have to address that acute urgency of overdose and harms while also remaining laser focused on prevention, and that we can do both of those things. And in fact, communities are doing both of those things every day, and we need to be there to support them. At CSAP, we have three primary goals for our work: preventing initiation of substance use, preventing progression of substance use to substance use disorders, and preventing and reducing harms. And we see there is opportunity for prevention across that spectrum. And our work is guided by SAMHSA's strategic plan, as well as the overall HHS overdose prevention strategy, which prioritizes primary prevention, harm reduction, evidence-based treatment, and recovery support services. One of the things that I've been trying to do in my role in the prevention space is really to get people to widen the lens of prevention and really think about the range of risk and protective factors at the individual, relationship, community, and society level. Oftentimes, prevention is sort of put in a box, and it's something that's done at an individual level. It's, assemblies in middle school or high school. But what we really see is that so much of what drives risk are connected to things like social determinants of health, adverse childhood experiences, and trauma. And if we're really going to get upstream with our prevention work and think about how do we address risk, how do we promote protective factors, we have to take that broader view that the socioeconomics, what's going on in someone's family, their community, their sense of safety and security, their ability to have economic, mobility, housing security, food security, those are all connected to either direct or indirect risk for substance use and overdose. And if we don't think about those foundational pieces of part of our prevention, we're never going to get to where we want to go. And it does have to be a foundational part of our work. And ultimately, we want to create an environment where individuals, families, communities are safe and able to thrive. Another thing that I think is often where prevention gets put in a box is that we're just looking at middle school or high school kids. And we know that from a true primary prevention perspective, if we are not operating earlier than that, we've really missed the boat on primary prevention. And we think about things like adverse childhood experiences. But when we also look at our data, we see that there's actually fairly high prevalence of 12 to 17-year-olds who have never used substances in their lifetime, in the past year, in the past month. But when we look at young adults, 18 to 25-year-olds, we see that that shifts very rapidly. And in fact, over half of young adults have reported substance use. And I think it really underscores the opportunity for prevention in that age group. Is if you think about, people leaving their, high school and moving into very different social environments, different social structures, support networks or lack of support networks, there is a real opportunity for prevention in that space. That's also where we've seen some of the rapid increases in overdose deaths among younger adults. Those people are often, not well insured or don't know how to navigate the system. So if they need treatment for mental health or substance use concerns, they are likely to fall through the cracks as well. So we really see that there are opportunities for prevention across the lifespan. Many people initiate substance use or use different substances at later periods of life, oftentimes because they are dealing with stressors in their life or mental health challenges or other situational issues that are going on. And that, again, provides an opportunity for prevention. So we've really tried to say, we definitely want to focus on upstream prevention, children and youth, but we don't want to miss the opportunity to also instill prevention to save lives. And I think the last part for me is, again, recognizing that prevention's work doesn't stop when people initiate substance use. That is one of our goals, is to prevent initiation in the first place. But we also recognize that people use substances, and we want people to stay alive. We want people to not progress to a substance use disorder and not need treatment. And so addressing that gap in between when somebody has initiated versus when somebody needs treatment is also the purview often of prevention. And there are opportunities to reduce harms, to help people on a healthier trajectory, and to save lives as a part of that sort of gap where people have initiated substance use. And the last thing for me is to just say that partnerships are critical. I think part of this conversation today is really to raise that it takes a variety of perspectives and players in a community to really bring to bear the various levers, policy levers, programmatic levers, gatekeepers to different communities when we think about equity and trust in the health system. And so we have to always be challenging our assumptions, asking who is not at our table that needs to be at our table, who is impacted, being data-driven, and saying, how do we engage other parts of our community that are not here when we're talking about resource allocation or we're talking about solutions to address the challenges in a community. So I can't underscore enough the importance of partnerships. It's one of our strategic priorities in CSAP, is advancing prevention through strategic partnerships and collaborations, because we recognize that no single agency has all the levers to make the impact that we want to make. So Sarah, I'll turn it back to you, but really appreciate the opportunity to provide some remarks.
Great, thank you so much. Mr. Rutherford, you can start. Thanks.
Very good. Thanks, Dr. Bagley. Thanks, Dr. Vakharia. The information that Dr. Vakharia provided is incredible, and I think that I'm going to focus my comments specifically around treatment and recovery. So at the National Council, one of the things that we're looking at very specifically is how do we approach the continuum of care. And just for a little background on the treatment model that has existed in the United States since, I guess, there was treatment in the 40s at Hazelden, has up until this point, it has been a programmatic model. And it is sort of when you go into treatment and you're assigned a treatment plan, or the information about what you need to get during that treatment has largely been based on a playbook focused on abstinence and the cessation of use, and then getting you out back into the community. So it's a very group-based or population-based model. Unfortunately, it's also an acute model. It's an acute care model. So the idea, and actually the number of days in treatment, sort of everyone's familiar with the 28 days concept, that actually didn't come from a clinician. That came from information derived from the military and what unit strength and unit capacity could stand to have someone out. So it's really important that we transition to more of an individually based treatment model. And that may sound complex, but it's really not. It really is the heart of sort of meeting people where they are. I think the policies specifically, it's one of the things that Dr. Vakharia mentioned, were some of the policies associated with this. We could spend a whole bunch of time unpacking conceptually which policies work for individuals in treatment. But I think the big picture is that treatment is more or less available now. The numbers are that 90% of the people that meet clinical criteria for substance use disorder are not receiving treatment. There is some treatment availability, but the challenges are around treatment fallout. They're around long-term completion of treatment and connection with community-based resources that continue to support recovery once a person leaves. I blame Dr. Vakharia. She stole some of my stats, but the numbers about buprenorphine access, the numbers about the way that methadone works in certain communities are jarring. And until such time as we address those problems, we're going to continue to see the same challenge. I appreciate the comments that Dr. Jones had around trauma. And I want to expand that a little bit in that I'm a person in recovery, and one of the things that is really important upon receiving treatment and getting back to your normal life are the social supports that exist in community. And I was lucky to have the opportunity I didn't need a ton of those supports, but I've witnessed a lot of folks that probably have the right idea, want to change the way that they're living, but are redeposited in communities that are simply not conducive to their recovery. So on the treatment side, I think that there are definite changes that need to be made as it pertains to the broader picture. Like when we talk about treatment, we talk about substance use disorder. Treatment is actually, in most cases, a small pivot point. The lifetime of recovery or wellness practices that individuals have are really the thing that keep them from having to recidivate or go back to treatment. Historically, those community-based efforts are poorly funded and not as available. The rise of the peer or the person with lived experience over the past 10 years is promising, but we need more. So, and I think I'll wrap up with this. The overdose crisis, and I really love that Dr. Vakharia said this, the polysubstance component of this has really changed the game. I'm in full support of not really talking about opioids, but talking about polysubstance. And then the next layer of that is talking about trauma, and then talking about living conditions for people that are experiencing these disorders at the base level. And I'll hand it back to you, Dr. Bagley.
Thank you so much for those remarks. I'm so excited, and I have so many questions for both of you, but we're going to keep going and then have a conversation all together. So I'm going to turn things over to Dr. Vázquez, and then we'll have a conversation all as a group.
Hello, everyone. I have thoroughly enjoyed listening to my colleagues on this call. It's been very elucidating. Even though this is work I do every day, I am learning so much here. I think I'm going to focus my comments on the importance of upstream earlier interventions and the importance of reduction of stigma. In my role as regional substance use disorder champion, I've spent the last 8 years really focusing a lot of efforts here in KP, Southern California, with working with my provider colleagues on kind of reminding them what we all learned in medical school, reminding them that addiction is, these are chronic medical conditions, not unlike diabetes and hypertension. These are not conditions where you tell someone, okay, this is your diagnosis, now fix it, change your diet, change your lifestyle, and I expect you to be better by the time I see you next. We know how to treat chronic conditions. And in fact, in Kaiser, we pride ourselves on our focus on preventive care, on wellness, and also taking advantage of our integrated health system. And I feel that the importance of really bringing different specialties together, different disciplines together, and realizing that we can't wait for patients to come to see the addiction specialist to get involved and to educate our patients and to really have better screening, early detection, and then know what to do once you do pick up that a patient is using. And again, focusing on this population, as Dr. Vakharia was saying, that kind of gets squeezed out. Of course, we want to do early prevention work, but what about those patients who are using, but they're maybe not, they haven't lost everything yet, but they're on a pathway that could really lead to very severe disease. And that's where I feel like we have such a strong opportunity, because those patients do see their primary care doctors for other conditions. They see their pediatricians. They may end up in the ED. So those are places where we need to really have more focus on interventions there. And I've been really fortunate to have amazing partnership with my regional leadership counterparts in these other specialties. More recently, we've been really working with pharmacy to improve access to these life-saving treatments such as buprenorphine, where, again, alluding back to Dr. Vakharia's opening remarks, a lot of times these policies that are well-intended often have these unintended consequences. So, for example, all of the restrictions around buprenorphine have created a lot of fear among providers about using buprenorphine. And the fact that it's scheduled similarly to the drugs that end up being part of the problem make it very difficult to access buprenorphine as part of the solution. Working with pharmacy and learning that they are getting red flagged if they make it, if they provide or stock buprenorphine. And I have patients who are really in recovery, they're doing well, and their biggest barrier to treatment is getting the medication from the pharmacy. And these are patients with insurance and they're employed that have every advantage, and they themselves can't access this treatment due to a lot of embedded administrative hurdles. So these are the things that I feel like we really need to focus on. And the other thing is we cannot underestimate or undervalue the importance of stigma, even within behavioral health. So, over the years, we've seen a lot of celebrities come out and say, I have bipolar disorder, I have depression. And now there's a lot more comfort with discussing these kind of conditions. But when it comes to addiction, there's still a very big disconnect there, where people who have addiction are still viewed as being defective, as making this bad choice and having these character flaws. And ironically, due to the multi-billion-dollar industries we have with alcohol, which is illegal, as well as now cannabis, we have a system where in society, these substances are really pushed on people. And then once there's a problem, then you're shunned and you're alienated. So a lot of the work we've been doing is, number one, trying to dispel a couple of myths. Number one, you don't need to be a specialist to diagnose a substance use disorder. So that's something we've been trying to teach, is that, our providers, our licensed therapists, and our mid-level or advanced practice providers, and our doctors who are not necessarily addiction specialists are more than qualified to use the DSM-5 criteria, to use screening tools to at least, early identify patients who might be either using in a disordered fashion or at risk to develop a substance use disorder early on. And the other myth we're trying to dispel is this, it's abstinence only, or we can't help you myth. That's been a huge challenge. We're working tirelessly with my partners to really try to turn that herd around, and to say that we don't need to not refer because a patient isn't maybe poised or ready to quit using overnight. There are so many things that we can do to help move that person along the behavioral stages of change. And so interventions in the ED, interventions in primary care, this is evidence-based. We know that when a person talks to their primary care provider, even for 5 minutes about alcohol use or other substance uses, they do start to change their habits. They start to become more aware of the quantities they're using. They have more education, and they're more likely to start shifting their behavior, even if they're not ready to commit to complete abstinence. So again, although the focus here, of course, is on opioids, it can't be understated how important it is to address all of these different addictive substances, because when we overly focus on one, we are at risk for excluding others, and many patients are using more than one substance. So we really also are trying to communicate that this addiction is often a childhood disease. It's a disease of childhood. Most of the patients I have started using at a very early age, 9, 10, 11, 12, so on. And so really kind of having this all lean in approach and really getting rid of the stigma is going to be so critical. We have also other challenges, even with our federal, our laws, in fact. So we have the Code of Federal Regulations that I think the intent is to protect patients by keeping these private or separate charts, when in fact it can often be an impediment to treatment, especially in an integrated health system. Even or no one's going to they can often at risk from a system where things in. So it's just, there's a myriad of things, but that's what I would say I want to see changes in. I want us to all lean in and not wait until patients are severely ill before we're really offering interventions and feeling that it's, untouchable of this treatment.
I think, Dr. Vázquez, your audio might be going in and out a
And
little
save
bit.
the patient's lives.
Oh, I think we missed some of what you said there, but there were some really important pearls. So maybe we'll just make sure your audio is working and circle back to follow up. But I think we can maybe transition to some of our questions that I think actually lead really nicely to some of the issues that you all brought up. And I think this idea that a lot of times substance use often begins in adolescence. And so thinking about prevention is really important. And Dr. Jones, you talked about the importance of sort of, I think, expanding sort of how we're thinking about prevention and thinking about social determinants of health and adverse childhood experiences. And was just, wondering, this anyone can answer though, sort of what do you think works? What are you seeing sort of innovative approaches in communities? And I think really building on that idea of like collaboration and sort of partnership and sort of understanding that it isn't any individual or organization or specific discipline that's going to be able to sort of really help us, right? Like we sort of need to find ways to really nurture those partnerships to sort of fully address preventing substance use and substance use disorder.
Yeah, I'm happy to take a first shot at that. I mean, certainly we see in research pretty consistently that those approaches that sort of look at multiple levels of the social ecology are the ones that are going to be most impactful. So, doing the more traditional things like life skills, training, other types of problem solving, conflict resolution at the individual level, coupled with engaging parents for positive parenting, setting appropriate boundaries, having discussions with kids around substance use, and then layering on sort of the policy piece, right? So what are you doing to look at economic insecurity among individuals, that those sort of packaged together, looking at environmental or built environment strategies tend to be most successful. I mean, I often reference a recent study from UNC researchers that looked at the Supplemental Nutrition Assistance Program, SNAP program, and they found that states that had greater flexibility and more generosity in their SNAP program actually had reduced rates of substance use and substance use disorders. I don't think people often think of that as a substance use prevention policy, right? But we know that those types of economic policies have been associated with reductions in child maltreatment or child abuse and neglect, which we know has a direct risk for substance use. In addition to mental health and many other challenges, it's a more traditionally defined adverse childhood experience. But it could also be that, because people are able to have some temporary assistance to meet their needs, it is reducing other stressors in the home, parental substance use, parental mental health challenges. So it could have both direct and indirect interplay. And I think that's where we need to be having the conversation. Like, we got to do the traditional stuff that people think of, but then how are we building on top of that to really change that context in the home and in the community?
Thank you so much. It makes me think, I know we have to be careful and evidence is very important, but I'm thinking of an anecdote because I was in clinic yesterday, actually, of a patient in terms of preventing progression of use who has daily fentanyl use, and she's had it for years and actually engaging, and she's been wanting to be on medication treatment, but it's been very hard to imagine doing that because she's experiencing homelessness with her partner. And like the most important thing is sort of survival, figuring out where, and she comes to clinic, we hang, we talk, we address anxiety. And through this program she just found out about, she got an apartment with her partner, so they're able to stay together. And the first thing she did was go to get started on methadone. And like, that is like a little bit of a, ideal, like it's, like I could almost cry, like, and just showing that then she was ready, like we'd been talking about methadone for months, but it was just not possible. And so I think sort of thinking about addressing social determinants sort of across that sort of that continuum of before use to sort of active use, is so important, and they're really important opportunities. Would either of the other panelists like to sort of comment on opportunities for prevention and collaboration and building in addressing prevention?
Can I just say, as the resident non-clinician here, because I know that I'm on the stage with a number of doctors, but in a very simple way, what you and Dr. Jones just described is sort of the heart of the issue. I mean, yes, there are clinical interventions for substance use down the road. There are things that we can do. There are medications that people take for substance use, but at a very basic level, if people don't have a roof over their head or a meal to eat, we're probably not going to get as far. There are those extraordinary individuals that muscle through all of that, but in general, the basics. How are we helping? If we really want to treat the problem, we have to address the basics. We have to address the basic social determinants of health, and I don't care for that word, but we'll leave it at that. Thanks.
No, I think it emphasizes this importance of sort of why we need collaborations and partnerships, so that different perspectives and different organizations that might have more expertise around housing or economic stability and then medicine can come together, so that people are sort of looked at more holistically and not reduced to their diagnosis, or the disorder that they may have. Okay, so we started to talk about some, I think, important aspects of prevention, certainly reducing the risks of harms related to drug use and treatment, but was wondering if we can sort of dive a little bit more deeply into harm reduction, and if sort of thinking about why is it important to focus on the harm reduction gap, and what are some, as we think about that, what are some promising harm reduction strategies that we need to explore and leverage? It might be helpful to sort of think about successful examples that any of you have seen implemented, and then opportunities to where you see where we could be doing a better job of implementing harm reduction interventions in our communities.
I feel like I'm hogging the time. But certainly, SAMHSA has been working to advance harm reduction efforts over the last several years, in particular, through engagement across prevention, treatment, recovery, harm reduction, recognizing that there are many interpretations of what harm reduction is. Sometimes people think of it more from an approach and sort of a concept in how you approach engaging with individuals. Other people focus, on interventions like, low threshold care, Naloxone, syringe services programs. We released back in January, SAMHSA released a harm reduction framework, which tries to sort of lay out all of those things, right? That there is sort of an approach to how we address individuals with empathy, dignity, respect, regardless of what's going on with them. But that there are also practices, core pillars of harm reduction. And I think what sort of with the phase where we are now is to work across the behavioral health continuum with people who are more traditionally aligned with treatment or recovery or prevention, recognizing that there is a natural tension there, because that is sort of counter to how some individuals in those traditional lanes might see themselves, but really to try to foster a dialogue that says there's probably more shared ground than people realize, and that we are all working towards the goal of respecting individuals, saving lives, and helping people on a healthier path. And sometimes that change might be very incremental and small, but it is still positive change. And I really appreciate, what Phil and others said, and certainly can relate as a person in long-term recovery. I was ready when I was ready, and there were people there to support me along that journey. And I'm glad that people didn't sort of discard me and say that you're a lost cause. And I think that, to me, we should be doing that in prevention, right? So if kids initiate substance use or they're using substances at school, what happens to them, right? They get sort of labeled as bad kids, they get expelled. But in fact, those are the exact people that we should be concerned with. There's probably stuff going at home. There's stuff going on in their life that they need support. And especially in a toxic drug environment where deaths among 12 to 17-year-olds are still going up, even though they're going down among some other groups. Like, we can't walk away from those individuals. And so you can apply sort of a harm reduction principle of everybody should have respect and dignity and sort of meeting them where they are. And that's what we're trying to do, across SAMHSA's portfolio, is to foster that dialogue, because we have to get back to why are we here? We're here because we care about people, and we want to, improve public health and improve lives. And so I think there's tremendous opportunity. But to Dr. Vázquez's point earlier, stigma gets in the way so often. And I think even just being able to sit down and have a conversation with people, it's very charged. It's a charged term. So I think there are a lot of opportunities for more engagement and finding more common ground.
Yes, I would just echo what Dr. Jones was saying. A lot of the work I've been doing at Kaiser is to work on how to approach patients and treat them with dignity. When our patients come through our doors, sometimes the treatment begins even before they pick up a single prescription. It starts when they walk in the door and our service reps greet them and treat them like people, and not, have this negative experience. They're already kind of bracing themselves, and they've already gone through a significant amount of shame, and who knows what it's taken to get them over the threshold and in the door. So we really are trying to teach to that. And as you said, meeting patients where they are. We cannot continue this idea of, well, we'll help you when you're ready. If a patient came into a family practice, their family medicine doc's office, and had a hemoglobin A1C of 15, there's no way that doctor would say, well, your hemoglobin A1C is 15, you're wildly out of control diabetic. You come back and see me when it's a little bit more like 7, and we'll bring you the rest of the way and change your diet, change your life overnight. And if you don't, that means you're a bad patient, we're going to fire you. So, these are very entrenched kind of, the stigma. It's so deep, it's so entrenched, and it's among, a lot of our providers who are actually, they're trained, they're professionals, and yet there's a disconnect there. And sometimes it can be personal. Sometimes people have, in their own personal lives, they have unconscious bias at play and all kind of things happening. But we've really been putting a lot of focus on what can we do for this patient that's right in front of us today? What can we do for them? And I always tell my patients, if you walk through that door and you're alive, I can help you. The only time I can't help is if you're dead. That's when it's too late. So we really have to kind of, switch gears as an institution and make things so much easier for our patients, and also just really improve the attitudes and the access to care. We would not have patients go all around town to look for their insulin. We would make sure that was stocked. So similarly, we need to stock these life-saving treatments and understand all the policies and politics at play that create these barriers, and work on, bringing them down and chipping away at them the best that we can.
Thank you so much. I know that your story of sort of a patient walking in really resonates. We in our program are very explicit with teenagers and families when they come in, and one of the first things we say is, we're not going to kick you out, and we're going to meet you where we are, and we offer treatment, but we're going to and harm reduction. And actually, like, the relief that we see often from not just the teenagers but the families too, because they've had these other experiences sort of in the healthcare system where things were we're rigid, and where I think they really experienced a lot of that stigma, is exhausting for people, and certainly isn't helping them. I was wondering, because this issue of rising overdose deaths among young people is also raised, and we're also talking about prevention and harm reduction. I'm wondering if anyone wants to sort of dive into that a little bit more deeply, and sort of how we hold the ideas of maybe saying to youth the safest thing to do is going to not be to use, and that we have this really toxic drug supply. And, I would suggest sort of also ensuring that they have access to the life-saving information they need to keep themselves safe, to help keep their friends and their families safe, and that they know how to use Naloxone. But I think this can be a tricky and potentially uncomfortable conversation for people, or that's what I've witnessed, and was wondering sort of how each of you are seeing that play out in your communities, in your different roles, and sort of how we can be most effective in developing policies to make sure that kids have access to the information that they need to, to stay alive.
I won't be shy. Oh, Phil, go for it.
Oh, I was going to hop in and say before Dr. Jones gets the mic. No, I just wanted to share something that I came across. I don't even remember where I came across this information, but I checked that it's accurate. That I believe this was in France, but 40,000 years ago, they found pipes with nicotine residue in them that were 40,000 years old. And the reason that I'm starting there is that there's a principle of harm reduction that says we have to accept that some people are going to use illicit substances. And I have no idea if nicotine was illicit 40,000 years ago. But I do know that one of the biggest challenges we have, and I don't know if it's unique to America, there's probably some other countries that have the same thing, but it's a really patriarchal view of substance use. Like, if we say this substance is bad, you can't use it, that somehow people will not do that. And there's no evidence to really support that, because people use drugs. I recognize that there are terrible health concerns with that. The overdose is a concern. But I think as long as we start with the perspective like, oh, this is bad, you shouldn't do it, the likelihood of us affecting change is relatively low. So I prefer, much like you said, Dr. Bagley, at the beginning, it's safer to do this, and we support you. Here are some things that can help you in your journey. I think that is okay. It's not to the extent that we crack down and create policies that are punitive, that does not seem to be fixing the problem. We can actually demonstrate that with an evidence base. So no patriarchal approach. As much stigma busting as we can do about substances. And I think that's at least on the road that we need to be on.
Yeah,
Yes, thank you for that.
Go ahead.
Oh, go ahead. No, I was just going to say, I think I was speaking to the fact that earlier that even among substances, there's a great deal of stigma, right? And a lot of it is based in industry and politics and the multi-billion-dollar industries that we have going. So yes, alcohol is legal. Yes, it's also among the top 3 leading preventable causes of death for people in our country, but yet it's viewed as less harmful somehow. Because those people are dying just all the time for decades. And now, a lot of focus, whenever we have a crisis, it's like that focus comes on that one substance. But in fact, there's, intermingling of all of these substances and addiction itself. So we have alcohol, we have cannabis, we have stimulants. And a lot of the people who are using these substances, they are inadvertently, getting a hold of other things, as has been mentioned earlier. And that's what we, really see. And we really want to let people know that we all have some degree of something. One of the most addictive substances is sugar, right? So, and caffeine. And how many of us, had our Starbucks or our coffee today? The issue comes in terms of the perception of risk, which, with some of the legalization, for example, of cannabis, there's a decreased risk perception among parents and users as well. And we have to just be very careful and say, look, we know that you may be using. Here are some ways to use more safely. We'd like you to not use it all, but we're not going to throw you away or kick you out or, be done with you if you don't do exactly what we want. Because I'm sure each of us can look and say, I could kind of work on this. I could improve this. We're constantly improving. The challenge now is that, before, when children or teenagers would experiment with drugs, the risk of them dying the very first time they tried was much less. And now we're in this much higher risk, higher stake environment. So again, I think that's really critical that we stop all of this difference, making this differentiation between these substances and villainizing somebody who's using one substance that's hardcore and maybe something else that's not hardcore, when in fact, it's all the same pathways, it's the same addiction pathways, and we really need to just come together and address, that person, what their needs are, and really, I don't want to say normalize, but not pathologize so extremely these use when we're all, a lot of people are using different things that are addictive and to different degrees.
I'll pass. It's been well covered.
That sounds good. I think I'm going to take the prerogative of facilitator and just add like one other perspective is just like as a pediatrician thinking a lot about injury prevention. It is like within our wheelhouse to talk about how we prevent injury related to drownings and motor vehicle crashes and so I think sort of thinking about the different framework and as a pediatrician, I'm thinking about sort of how do I talk to them about this and sort of ensure that this, should be within scope and in terms of the advice and counseling people are given. So let's turn and sort of talk a little bit about people who have opioid use disorder and sort of how we can best support them. So the first question is really about medication treatment and access to medication treatment for opioid use disorder, which we know is life-saving and important and also can be really difficult for people to access. What do you think the public policy changes at the federal or state level could be to improve access to medications like buprenorphine or methadone? And what are some of the barriers that you see as well?
I'm going to just take one segment of this. When you talk about barriers, I've been doing some research on pharmacy deserts, and I don't know if that's something that the general public talks about all that much. But as we talk about buprenorphine prescriptions, which are on the rise, so the stat that Dr. Vakharia gave earlier is that is troubling on its face. The fact that in Black communities, people are 60% less likely to receive a prescription, that is a problem. But even for the group that does receive the prescription routinely, and this is not necessarily a Black communities thing, but it certainly is an urban communities thing. The number of pharmacies available to people that are trying to do the thing that we've told them to do, which is you need to get some help with your opioid use disorder, that number is remarkably small, and it does mirror communities of color and other and communities of color and poor communities are mirrored in that pharmacies are not as readily available to them. So in a very simple, just sort of straight up way, perhaps if we built more pharmacies or if we made more pharmacy services available to these communities, we could have some direct impact. There are challenges with the methadone system in terms of transportation, cost, and people's ability to make it there on a daily basis. A lot of the methadone clinics have a very sort of carceral feel to them, and you show up, you get your dose, and you shut up, and you go on about your business. There is a kinder, better way to do that stuff as well. So I know I only talked about two barriers, but just access, frequency of access, and number of pharmacies are a problem. But there are certainly more barriers, and there are some solutions. But I'll leave that to my esteemed colleagues to share.
Yeah, I definitely think that this is complex. I've done a fair amount of research in the buprenorphine space over the last several years. I mean, and we pretty consistently see that, well beyond the data waiver, which everyone said was the barrier, which I never really thought it was. I thought it was a convenient excuse. But, that there are barriers at the individual level, at the system level, at the payer level. And I think it's really chipping away at all of those is where we then start to realize a larger shift in prescribing. But I mean, I think there's provider stigma towards OUD, there's stigma towards the medications themselves, in addition to stigma towards OUD. So we have to work on that. I mean, it's pretty consistent in research that we've done that, providers don't always feel confident in managing those patients. So how do we think about systems to support those individuals who are not specialists to provide care in a confident way, but they feel like they have a backstop where they could reach out to a specialist if they run into trouble with a patient. And so, there are various models, hub and spoke, et cetera, that have been put in place in different communities to address some of that. I'm hopeful that SAMHSA's recent updates around OTPs will also address some of the barriers that Phil mentioned, increased flexibility on take homes, just really trying to update those regulations that had been updated for quite some time. And then, the pharmacy issue is definitely, I think, front and center. We have done several roundtable discussions with stakeholders over the last couple of years to try to understand the pharmacy issues. Some of this is tied into like suspicious orders from multi-district litigation. But I also think it's tied to stigma. Even when pharmacies exist, patients can't necessarily get the medications in many communities. And there's sort of this cascading effect, right? So stigma could be the impetus in one place. So say in a rural area, somebody has access to a pharmacy, but the pharmacist doesn't know the patient, so they want to dispense it. So then the patient travels 50 miles to somewhere else, but then that pharmacist doesn't trust them because now they traveled 50 miles. And it's not worth their time financially to take the time to do this, to verify with the patient or with the provider, because of low reimbursement rates or dispensing fees at the pharmacy level, sort of this cascading thing. And then they're bumping up against their opioid procurement order. And so there are really a myriad of factors at play to address access to buprenorphine. But I think we've done a pretty good job of identifying them. Now it's like, what are the policy solutions? Not always at the federal level, sometimes at the state level or even local level or even corporate level. What are the solutions to the problems? Let's stop defining the issues. I think we have them well covered, but then like implementing solutions.
Great, thank you both so much. Before we turn to audience questions, I have one sort of last question I want to ask the group. So we've talked about sort of significant disparities in overdose rates and also lower receipt of treatment among Black, Latinx, and Native American populations. And from your vantage point, how do we ensure that the programs we are creating, the policies that we are supporting, are going to foster equitable approaches for care for all people? And sort of, again, going back to Dr. Vakharia's sort of last slide, not exacerbate existing inequities.
This is actually a larger question than as you described, in that, so let's start with treatment completion rates. Treatment completion rates for people in minoritized communities are typically lower than others. One of the reasons that we believe that is the case, we know that it's the case. One of the reasons that we think it's happening is a lack of cultural competency in treatment programs. And the reason I said it's a bigger question than that, because we can make treatment more accessible. We can give people more access to it, but the outcome of that, here's another stat, right? The business of people getting kicked out of treatment is higher, specifically in the Black community. If we don't address that, we can have as many pro-treatment policies as we like, but we're still going to get the same results because there's a lack of cultural competency in a number of these. And that cultural competency is not just about giving counselors a training or giving clinicians a training. It is about having clinicians that mirror the population. We know for a fact that is more effective. And in my own personal experience, having someone that sort of could relate to me both on an intellectual and a cultural level made a big difference for me. It made a big difference for my approach to recovery and for behaviors that I needed to model. So it's not just more treatment. It's, yes, more treatment, more culturally competent treatment professionals, and more people of representative cultures involved in treatment. I'm not going to get into the physical space and some of the environments where treatment is delivered. That's a different subject, but that needs to be addressed too. So it's a broad issue.
Yes, I could just echo what Mr. Rutherford was saying. I think there have been some changes in the last decade in terms of the way we are trying to improve the amount of providers that we have, the amount of specialists that we have in addiction medicine. Around 2015 is when the board certification process changed and expanded from, previously it was just family medicine, internal medicine, and psychiatry that could go on and get a fellowship in addiction medicine. And now, thankfully, it's open to over 21 primary specialties. So we're seeing now in our recruitment, population in the recruitment pool, increasingly more doctors who are IMFM trained or family medicine, internal medicine trained, or OBGYN or anesthesiologists or any or emergency medicine. We're seeing a lot of doctors who have a different primary specialty kind of coming in. And that's what we need, though, at all levels, not just physicians, but we also need advanced practice providers. We need more therapists. We need more at every level. And I do think there also needs to be more incentive and a greater effort to get more peers involved and develop the peer support program. Because again, that relatability, being able to connect with somebody who understands you both culturally, intellectually, and who's really can make that kind of human connection is really critical. And we do see much more success that way. So, within our organization, within KP, we've been really working to recruit and identify people who are already, have a penchant for this work, for this population, so that they can, sort of spread out and make everyone feel more comfortable with it. If a pediatrician has started, addressing this, maybe their colleague who might previously have felt very uncomfortable addressing substance use disorders can see, oh, you know what, you did it, I can do it. We've developed a lot of tools in our electronic health record to help with decision support, so that we can really just expand the amount of people who are able to do these treatments and address this population. It can't, we have to move away from the bottleneck, as was said, and no amount of policy change will help if you don't have that great representation in the workforce and in the treating workforce to reach patients of all different backgrounds, so that they can feel that human connection first of all, and then go from there.
Thank you so much for that answer. And I'm really glad that we got to this sort of workforce issue as a sort of key component to, I think, address equitable care. Because it is, any of us who are on the ground know that we really have a there's a real crisis in terms of having enough people to do the work, and of sort of, as you're mentioning, diverse disciplines as well. So we're going to transition to the sort of audience question that's related to naloxone. So, naloxone is the antidote for an opioid overdose. And there was an important change that happened last fall, and it's available over the counter now, which is exciting. But then I'm sort of hearkening back to Dr. Jones's point about it's not as simple as like Xing the X waiver. It's available over the counter, but how can we make sure that naloxone is truly available to the populations that are at highest risk for overdose, so that we don't have, where we may have communities that are saturated with naloxone, which is great. We want to get it out there, and then also still have the communities who are at high risk for overdose and may not actually have the access that we sort of hope for them to have.
Again, I think this is where data are so important. Who is most likely to experience, witness, or respond to an overdose? People who use drugs. So how are we prioritizing that population in our naloxone saturation efforts? I think that's a fundamental question, that it's not simply a number, that there are X number of naloxone or nalmefene products distributed per number of non-fatal or fatal overdoses, but it's really who is it getting to? And, how are we approaching that? And at SAMHSA, we've been doing naloxone saturation work across both the Center for Substance Abuse Prevention and the Center for Substance Abuse Treatment with states. And we've really tried to move away from sort of like a number-based saturation to really thinking about abundance and populations at risk and, monitoring, are we getting to those areas where data suggests that the risk is greatest? And I think people originally with OTC products thought, all right, well, now it's just readily available to everybody. but it is expensive. I mean, certainly for branded products. And it's not necessarily the place that everybody wants to go to get naloxone, right? They may be going to a syringe services program. They may be going to a treatment program. They may be going to some other trusted place. So how are we engaging those trusted places as also venues to get naloxone into the hands of individuals? But it is, it's really, really important. Because naloxone and opioid overdose reversal medications are still a limited commodity. And so if we are diverting those products to individuals who are much less likely to witness or respond to an overdose, we are inherently not giving it to the people who are most likely to respond. And I think we just have to be very intentional and thoughtful about that, because what we have seen is that there's an imbalance. There are some areas that appear to be well saturated based quantitatively, yet it's clearly not having the impact that individuals hoped that it would. And when you start to look under the hood, you really do see that where it's going, who it's going to, is really not the population that is going to most likely respond to an overdose.
On that
Oh,
note,
go ahead.
No.
Go ahead. We're running out of
Okay.
time, and I want to make
Okay.
sure everyone gets like their closing thing. And so, but if you
I'll-
want to, yeah, answer.
I'll be super
Go
brief. In doing research for another presentation, I happened to overlay the COVID-19 data with overdose data and the population mixes in those. And if you look at the sort of, well, I don't know if it's called this, but the first wave of COVID, there was a lot of death in communities of color. But once the vaccine got into the community, and yes, there was some resistance, but you can actually see on a chart how that impacts people there. So I said pharmacy deserts. There's also naloxone deserts. So what Dr. Jones said is critical in terms of the way that we provide these substances out to communities. That's all.
That's not just all. That's really important. That's really important. Thank you. So we are near the end. I want to just thank you all so much for being here. I feel like I learned so much. I'm excited to, go out and continue the good fight. If you sort of have some final thoughts for participants though today, in terms of what you hope they have learned, and now we're going to go out and sort of maybe do something differently, change their practice, advocate for a new policy, sort of what would it be?
My message would be that we really need to make sure that access to the treatment is equal, if not greater, than access to the actual substance of abuse. So whenever possible, we need to reduce those barriers. We need to look at changing the scheduling of buprenorphine, for example, so that it is, there's greater access to it at the pharmacy level, at least. And we need to also just continually meet people where they are. And know that it doesn't have to be this either or. It doesn't have to be, abstinence, and that harm reduction doesn't promote use, but it tries to keep our patients alive and well enough so that they can move along the behavioral stages of change and hopefully really change the trajectory of their disease course. Those would be my big messages that I hope everybody takes home.
I would say, coming from the prevention standpoint, is that there's just so many opportunities in prevention. We see this massive mismatch between communities that are ready, primed to do prevention work and available resources to support that work. So I think wherever you sit, engaging in community-based prevention, thinking about policies to support prevention efforts is really important. But I think more than anything, if there was a nugget of something that you heard today and you've been sitting on the fence of engaging in some way, get engaged. There is more than enough work to go around to support the change that needs to happen in communities. So I say look for that piece of something that was of interest to you, find out more about it, and get engaged.
One word: community. I do federal policy work, and I empathize with the difficulty of getting resources from the Fed down to the community, but that's where the help is needed, and that's where the work is to be done. It's in community. If you have an opportunity to contribute, support, or make community care better, I think that is the thing that will pay the greatest dividends.
All right, well, thank you all so much. This sort of concludes the panel discussion. We're going to transition for some closing remarks, but really appreciate everyone's participation this afternoon. It's afternoon for everyone now, so.
Great, thank you. So I would like to thank our esteemed panelists as well for sharing both their personal and professional experiences and perspectives. So thank you, Dr. Vakharia, Dr. Bagley, Dr. Jones, Mr. Rutherford, and Dr. Vázquez. This was a very powerful event where we covered a lot of ground, thinking about the waves of addiction and the poly substance uses, as well as thinking about prevention and protective factors, food, housing, trauma supports, etc. So quite a lot covered today, and we really appreciate the caliber of today's conversation. As we close out, I also want to include a thank you to the Institute for Health Policy team, Renee Gross, Kristen Joyce, Ben Thrutchley, Nicole Perlman, and as well as our colleague, Leah Newkirk, who has often lends her expertise to our team. We also had a great group of subject matter experts throughout Kaiser Permanente that supported the development of today's event, so we want to thank you. And we also want to thank Spark Street Digital for their ongoing support of our events. We'll post this recording of the event on our website in the coming weeks. And you should also see a QR code right here on the screen. And if you use that, you will please take a survey, provide us some feedback. We always look at it, and it certainly has helped inform conversations that we plan for and that we have, including today's. So thank you very much for joining us. Have a good rest of your day.